When saving lives is what you do, your standards are anything but standard. In fact, you set them higher than most to deliver results that patients can depend on. You refuse to compromise. We couldn't agree more. We are Edwards Life Sciences, and like you, we believe that good is never good enough. Rising to the challenge of today's TAVR patients isn't just a mission, it's a commitment. And because you set a higher standard, we set our sights on meeting you there. Welcome to the higher standard, your standard. Learn more at edwardstavr.com.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. This one comes to you on Valentine's Day, so a very happy Valentine's Day to all of you. And while it's Valentine's Day, I think it's important to talk about heart health, and it is the Heart Month. And I think I'm really honored and ecstatic to have a colleague on today's show who has done some seminal novel work in acute myocardial infarction. So I'm going to introduce him formally. Dr. Rohan Dharmakumar is the executive director of the Krannert Cardiovascular Research Center at Indiana University School of Medicine, my new home. And, Rohan joins us to talk about his work, which was published earlier this year, actually last month, in Journal of the American College of Cardiology, JACC, on hemorrhagic myocardial infarction. So Rohan, thank you so much for doing this for us, and welcome on the show.
Yeah, thank you, Ankur. Real pleasure to be here.
I'm going to start asking you about the concept of hemorrhagic myocardial infarction. Why? First off, how did you stumble upon this concept? And if you can, educate us more about the subtype of hemorrhagic myocardial infarction from some of the other garden variety myocardial infarctions that we see as cardiologists.
Yeah, so it actually is serendipity how I got started in this. I met, one of my earliest collaborators, Dr. Andres Kumar, while I was visiting in Calgary. I think it was 2005 or so. And we got talking about how there could be hemorrhagic myocardial infarctions that are happening in heart attack patients. But there's a lot of parallel with that, with hemorrhagic stroke. And we were at that point kind of spitballing about ideas where hemorrhage may actually be not a good thing to happen when you're revascularizing patients. And so that's sort of the introduction in many ways. But perhaps before that, there's some work that was going on from my, starting days in Toronto in Grant Wright's group. They were also studying hemorrhagic infarction in large animal models. So there's sort of a preformed idea in my mind about hemorrhagic infarction, but it wasn't something that I was studying very actively or even got started in it till I really met Dr. Andres Kumar, who's now in Sudbury doing a lot of great good work in hemorrhagic, and we still collaborate, and he's actually one of the collaborators on this paper. And so we said there was a lot of activity that was starting around 2005, 2006 around hemorrhagic infarction because MRI has become a novel tool for assessing tissue injury. And so we said, well, and Andres at that time was developing a method and validating it that's based on MRI for imaging intramyocardial hemorrhage. And a lot of his work was done using large animal models. And And he was testing it in patients as well. And so he had validated this method called T2 star weighted MRI approach for imaging intramyocardial hemorrhage. But the concept that hemorrhage may actually be bad did not emerge till about 2009 timeframe with work by Ganami and others that was published in the European Heart Journal, which said, we did studies in patients, I think it was around 50 patients or so that they studied, that they could identify to be hemorrhagic versus non-hemorrhagic. And they showed that in following patients over a 4-month period, that the remodeling that happened in these patients were, at 4 months were different from the patients that didn't have hemorrhagic infarction. And, on the backdrop of all of this is this concept of, large MIs do poorly, right? And that's a fairly accepted concept. And so people said, well, yeah, that's because, because those hemorrhagic infarcts are large. And that's really why, why those patients actually see adverse remodeling in their hearts and go on to develop heart failure and things. But so we were at that time, even 2007 and 2008. This time we were thinking, how can we show hemorrhage is actually bad in the heart? Like, instead of just following patients, or what can we do that could start getting us closer to understanding how bad hemorrhage is? And so in that setting, we started to look at large animal studies. At that time, I was in Northwestern University in Chicago, and we were creating animal models, large animal models that would produce hemorrhage. So, first time we did this, I remember it was an evening, and we had actually successfully created a hemorrhagic infarction. There was a lot of excitement with the group and being able to see hemorrhage. And we were seeing this with MRI. So that was the first time I actually had my hands really deep in it and to understanding this phenomena actually does happen, and we can visualize it beautifully with MRI. And so one of the things that we did, at that time, the concept was that hemorrhage happens and then it essentially dissipates, over a few weeks. And some of the other groups were showing that to be the case in using pig models. But, the infarcts got very, very thin in pigs, not very much similar to what we see in patients. And so for that purpose, dog models were good because, they don't really thin out very, very fast, and they're very similar in many ways to humans when it comes to acute myocardial infarction. And so what we would do is we'd say, okay, well, let's just make sure that we go through this process and try and confirm that to be the case. So that being, if we were to follow these animals over a period of time, then we won't see the hemorrhage or remnants of hemorrhage. So we did an acute MI study with MRI and then followed it up with an 8-week period after revascularization in these animals with hemorrhagic infarcts, and we did an MRI study. So I still remember sitting there in front of the scanner at 2:00 in the afternoon on a gray day in Chicago, and I'm looking at these images that are coming out first time, and I see this in the infarct zones. There appears to be signal that looks like there's hemorrhage. And so this is 8 weeks out. We're not expecting it to find any hemorrhage at that point in time or any residual from hemorrhage. And I said, well, that must be an artifact. And so I said, well, this might be some aberration with the studies. Let's try and do this, in the remaining animals. So the data kept coming out the same way. So we were seeing signals of these iron or, this hemorrhage, which is visualized because of the iron particles that are there, and we can still see it. So, there's this concept of late gadolinium enhancement in MRI, and you can look at fibrotic tissue or so-called fibrotic tissue in the chronic phase. But that's what people did. But if you were to run this so-called T2 star method that Andreas had been developing, then we were able to see these very rich regions that were suggestive that there was lots of iron particles that may be there. And so what we then did is, well, okay, this maybe it's an artifact, maybe not, but we're seeing it in so many animals. So let's go and, get the hearts out and do, additional analysis, histology. And so when we did the histology, sure enough, we definitely found lots of iron particles there. So the question is, so the iron is not leaving the heart as fast as we thought it was going to leave. So what does it mean? Does this have any implications? So that led us down the path of looking at what does iron do in the heart. And so we did assays that would look at, newly recruited monocytes into that infarct zone. And what we were finding was just really exciting in many ways, because it's the first time we were seeing this. We were seeing a lot of inflammatory activity in that heart muscle that had an infarction, but those infarction that had iron particles. Now, in contrast, in infarcts that were non-hemorrhagic, in the acute phase, we don't see any signatures from the MRI for them to be hemorrhagic. That's really the only non-invasive way right now to be able to detect hemorrhage. And when we follow them up at 8 weeks, we don't see anything there either. And then not much of a surprise. And when we go into histology, we don't see any iron particles either. And we don't really see any inflammation either, right? So we said, okay, we're starting to see these active monocytes that, that are infiltrating and becoming macrophages. Can we look at this a little bit deeper? At that time, I was transitioning from Northwestern to Cedars-Sinai Medical Center, and very similar questions were asked. Hemorrhage is found in large infarcts and this and that. And we said, okay, let's look at this a little bit more closely and look at, can we see any cytokines? So we started looking at this, and we started to see all the pro-inflammatory cytokines that were in the infarct zone, in the iron-rich zones. And so we were seeing a lot of elevation of IL-1 beta and TNF-alpha and MMP9. Those are all characteristic of really contributors to adverse remodeling, and really alter the balance between collagen and elastin in the infarct myocardium. And we were also seeing that if you let these infarcts go for a little bit longer, they were also thinning out. And that's all can be explained in many ways by these inflammatory molecules. So the question is, why is this happening? At that time, I met a very, very bright immunologist, David Underhill, and I was just casually talking to him, and I said, there's these iron particles that are there, and he said, well, could they be in crystalline state? I said, well, I don't know that. And so this would take us to another path to Washington in the Pacific Northwest National Laboratory, where we would study these iron particles, and we were able to show, those remnant, content out of hemorrhagic infarcts were indeed crystalline. So this brings up a very interesting concept, right? Because that in gout, you have a lot of silicate crystals that drive pro-inflammatory activity. So then we published a paper, I think it was in 2016, where we showed that hemorrhagic infarcts resolve into these chronic iron deposits that are indeed in crystalline state. And it's the crystalline state structure that perhaps is driving the inflammatory conditions around infarct zones. So that's really my introduction to hemorrhage that would take us to a point where we would say hemorrhage actually does drive these type of phenotype of macrophages in the heart. But that still didn't answer this question, why these infarcts are large. And so that would take us a lot longer to answer. And that became the subject of this paper that we published in January in JACC.
I appreciate the long-winded answer. I mean, I think for a lot of us who are clinicians and take care of patients, at the bedside, or even, certainly in the cath lab as proceduralists, I mean, these are important concepts for us to understand and harbor and digest, because, it could have ramifications in terms of how you manage these patients clinically. And you and I have talked about this off the line, certainly. But, fascinating as to how you stumbled upon the concept of hemorrhagic myocardial infarction and how that led into the work that you just published last month. So, just continue, because, I was, even though this was a long-winded answer, I was focusing and listening carefully because I was learning as you were speaking. So educate us as to how a hemorrhagic myocardial infarction happens to be a larger myocardial infarction on cardiovascular imaging.
So, this the story continues and starts to branch out a little bit more. We were asking a couple of different questions at that time, around 2015 or so. We said, does this have any ramifications on electrophysiological constructs? Does it change the electrical, for instance, are there reentry circuits that are here because of this iron, residual iron? So that led to papers that we would publish that show that indeed that, in the long term, there are electrophysiological consequences by the presence of iron. So that led to that direction of work, and it's still going on. And then we asked, okay, well, we're studying these in animal models up to 8 weeks. What happens if it goes on for even longer? Let's say 6 months or a year and a half. Now you can imagine that these studies are extraordinarily expensive, especially when you're working with large animals. And so really was super thankful for NHLBI to continue to fund us in a very significant way to carry on this work. And hopefully I'll have a chance to talk about some of the things that we're working on that direction. But the question about why these infarcts were large were difficult to answer, because we know that, if you tie, if a coronary becomes obstructed, then, how much infarct that is developed really is related to the area at risk. So the question is that, for us, we needed to look at the data, and we needed to normalize all our findings by the area at risk. And then only then we could dichotomize the infarcts into hemorrhagic and non-hemorrhagic pools and be able to characterize them as something that drives a large infarct or not. And the question is, how do you do that, right? Because the classical way of identifying area at risk is really sort of an invasive procedure. You inject a dye, you euthanize the animal, and get the hearts out, and you get the area at risk. But you will not be able to assess the size of the infarcts in a sort of a temporally resolved fashion after the infarct period. So that was one challenge. But we were thinking, well, there's this method that was coming out from NIH, Dr. Andrew Rice group, and also in connection with Matthias Friedrich, they were describing a concept called T2 MRI, and that can potentially give us area at risk. But then it really devolved into a lot of complicated questions that people were asking that, essentially was not everybody was on board with that concept of T2-based area at risk. So we didn't really have an imaging-based approach for looking at area at risk and then be able to assess infarct size over a period of time. So fortunately, around that time also, Siemens was releasing their scanner. It's a very novel scanner at that time. It was a whole body PET MRI system. And what that allowed us to do is allowed us to collect PET data. And some of you may know that PET is really the gold standard in terms of looking at blood flow, although these days MRIs as well, but PET was the standard at that time, and still in many ways it is. And then MRI data can also be simultaneously acquired, right? So MRI would give us, ability to characterize the size of the infarct, and that's really sort of, a gold standard that was developed by Bob Judd and Ray Kim when they were at Northwestern, and continued to do fantastic work with that, and really became a big story to tell in cardiac MRI. So we were really it just clicked to us that, look, we may be able to look at, really true gold standards in vivo with both of these methods. And so we said, okay, let's try and do this cardiac PET MRI approach. So for this, what we did is we were working with a wonderful collaborator of mine, Frank Prado, and colleagues in London, Ontario, in Canada, and we would do these studies. What we would do is we would, prep the animal and have a snare around a mid-LAD, and we would bring the animal into the MR scanner. And essentially, we will create the infarct by tying that coronary for a very controlled period of time. And during that time, we would acquire both the MRI and PET. And what this allowed us to do is to look at volumetrically, we were able to look at the perfusion territory, essentially the area at risk, which is really the territory within which infarcts develop. And the whole idea of reperfusion therapy is to really limit the infarct size inside that area at risk to be as small as possible. So one concept around the ischemia is that, you want to limit ischemia so you don't have so much of an infarct burden inside the area at risk. So, so goes the phrase time is muscle. So we all know that longer the ischemia period, the bigger the infarct, right? And so obviously we've gotten a lot better in terms of reducing the infarct size. So these animals that were getting infarcted inside the magnet, it's a very lengthy study that involves collecting MRI data and PET data at the same time, and then quantifying the area at risk and quantifying the infarct size really 1 hour after revascularization, but also looking at the area at risk prior to revascularization based on PET. So then what we would do is we would recover these animals and we would, scan them every 24 hours. So we would scan them at 24 hours, 48 hours, and 72 hours, and 5 to 7 days. And we would also scan them at 8 weeks. Right? And when we started to pull the data in the right way based on evidence of hemorrhage on the basis of MRI data, what we were able to see was really remarkable. What we found was that when we normalized for the area at risk and we looked at the infarct size, there was absolutely no difference in infarct size at the time, 1 hour after revascularization. So that is essentially telling us that the infarcts that have happened up to that point whatever the size it is, that is indifferent between infarcts that were hemorrhagic versus non-hemorrhagic, which we will find out, at 3 days post-revascularization on MRI, they did not have any difference in infarct size. So the ischemia is the only factor that determined the infarct size at that time. Makes sense. But then once we started to look at the data over a period of time, at 24 hours, 48 hours, and 72 hours, the way this whole picture was evolving was fundamentally different in that the infarct size on non-hemorrhagic infarcts were relatively, any changes that happened there were typically about no more than 20% or so increase from the time point of 1 hour after revascularization. This is 24 hours, 48 hours, I think, and it peaks around 48 to 72 hours or so. This sort of plus minus 20%. Well, not plus minus, really maximum of 20% increase, and that's known to occur. That's been the term that people use, is ischemia reperfusion injury. And so that's explainable. But then when you look at the infarcts that became hemorrhagic, that was massively different. It was fourfold increase. So it was the infarct size really increased by 80% or more on the infarcts that were hemorrhagic. Remember, the area at risk was the same, or the normalized area at risk to the infarct size at 1 hour was the same. But then now when you're looking at it at even 24 hours, the infarct size is fourfold bigger and remains that way over that 1 week period in hemorrhagic infarcts. And it's a totally different case in cases where you do not have hemorrhagic infarcts. Now, we thought, well, people might say, well, this could be, this hemorrhage is making the whole muscle area bigger and everything else like this. And so we said, okay, let's also look at what the scar burden is by 8 weeks. A lot of the edema is resolved and things like that. And when you look at the scar burden, it's absolutely the same case we found with the infarct size. So the scar burden is actually multifold higher in hemorrhagic infarcts versus non-hemorrhagic infarcts, supporting the concept that hemorrhage is actually a major driver of infarct size. Now, so this is all good. This is, essentially, Reimer and Jennings' concept of a wavefront that, infarcts really proceed in a wavefront fashion, and really kind of capturing, going from the endocardium to the epicardium with this longer ischemic period was obviously, it's a hypothesis, but it's really well accepted in the field to be true. But what we were seeing is also an infarct expansion that was post-revascularization that was also happening in a wavefront, because when you look at the transmurality of the infarcts, that was also expanding. So perhaps not surprising, given the information that I've already mentioned here, that the infarct size was much larger, so it has to expand in some way. But we were seeing this sort of this wave that sweeps from the endocardium to epicardium and really taking over much of the salvageable myocardium. So in these animals, at least, we were looking at the infarct size and the salvageable myocardium is tremendously diminished. I mean, to the point where revascularization really didn't make much of a difference in these, in the final infarct size on these subjects. Now, so this is all animal work, and it had to be done this way. You can imagine that we are imaging so repeatedly that it's very difficult to undertake these sort of studies in patients. So we said, well, what is the one thing that we can do to look at how these infarcts actually evolve in patients? So we said, okay, let's take a look at something that we do know quite well in terms of myocardial injury, which is troponin. And so we said, okay, let's look at troponin in a collection of patients that eventually become revascularized. And so what we did is we did a study in about 64 patients at the end that we analyzed, where we imaged, we were essentially tracking troponin pre-PCI and post-PCI, 12 hours, 24 hours, 48 hours, very similar to the way the animal studies were done. And what we found was actually quite remarkable. Before I get there, we also did an MRI in these patients at 3 days post-PCI to identify who had been hemorrhagic and who didn't have hemorrhage. And so when you take a look at the entire troponin data and you dichotomize the data into hemorrhagic cases and non-hemorrhagic cases, what we were finding there actually remarkably parallel what we were seeing in the MRI and PET data in large animal models. That is, that the troponin actually peaks very early, within 24 hours or so, in hemorrhagic infarcts, and then flattens out, but it stays relatively, high, but it's starting to decrease. In non-hemorrhagic infarcts, what we found was that the troponin values would increase and peak around 48 hours or so, and then come down. But during all of these times, the troponin values in hemorrhagic infarcts always remained high, within that 72-hour period that we were looking at, supporting the concept that what we were seeing in animals can actually be reproduced in patients, but now using troponin as a marker. So again, a long answer, but really that's really what it showed. And that establishes, the concept that hemorrhage is a second determinant of the final infarct size. We all know, like I said, ischemic burden or the time is really important in terms of how much muscle we lose, but hemorrhage really does look like another major determinant of infarct size.
Yeah, no, this is just an excellent chronology of events leading up to the concept of hemorrhagic myocardial infarction. And congratulations to, years of work from you and your team, I think across the spectrum of different institutions now, as you explained so eloquently, that have led us to, where we are today. I'm going to spend the last maybe 5 to 8 minutes of the podcast, and thanks for all the explanation and all the education as to where do you see this work moving forward in terms of its clinical application, because this is an important signal. I think it's got important prognostic value for our patients. And is there anything we can do to mitigate hemorrhage in a subset of patients with myocardial infarction, and how do we go about the application of this incredible knowledge clinically at the bedside?
Great question. And that's really, going to be the next frontier, I feel, for hemorrhagic infarction. So, with my move from Cedars-Sinai, we did tremendous amount of work, wonderful collaborators. Now here in Indiana, we want to take the next steps on hemorrhagic infarctions. So I would characterize the development of things to come in 3 phases. I will start with the back end. The back end is what I've actually told you in the beginning, which is really hemorrhagic infarctions leading to chronic iron deposits and a chronic inflammatory period that is a lot longer than non-hemorrhagic infarcts. So I think there could be therapies, including colchicine and other anti-inflammatories, and perhaps even, ion chelation therapies that can potentially benefit patients there that have had a hemorrhagic infarction. And we have another paper that is evolving that is showing that the hemorrhagic infarcts are actually at the core of further negative remodeling besides infarct thinning. And I think all of those can potentially be halted with novel therapy. Some of them that are already in existence. So essentially, it's a relabeling for a different use. So that would be one area. And the second is obviously prior to this, the second question I answered, which is really about acute MI size. So the acute MI size driven by hemorrhage has a lot to do with the components of hemorrhage and what it does to the cardiomyocytes. And there is also very exciting therapies that can be developed to really mitigate the damage that hemorrhage drives. So essentially there are two components, right? So one is the early damage and then the late damage, and they're both going to have different forms of therapies, really trying to address the damage, the different types of damages that come out from the different phases of hemorrhagic infarction. So that is two phases, but there's a third phase. There's essentially, phase one in many ways is that how do we think about reducing hemorrhage? Are there ways of reducing hemorrhage? So that information is evolving from, a meta-analysis that, Raj Gupta at Toledo is really working on. And then it's showing that there are critical conditions that can actually drive hemorrhage in one person over the other, not just ischemic burden. Clearly that matters as well. So the question then is that, are there ways that we can minimize the possibility of the development of hemorrhage, even at the level of, when PCI is being performed? So, there's some concepts that we are working on, but I'm sure there's lots of different ways of looking at this. So if I were to kind of put all of this together, I would describe this very much in this way. There's a phase one, which would involve prevention of hemorrhage or really reducing the evolution of hemorrhage. The second phase, which would be associated with limiting the infarct size because of hemorrhage. And the third phase, hemorrhage has already happened. What do we do now? And that would be potentially a pharmacological therapy there to reduce the inflammatory period or the extent of inflammation that is really engulfing that infarct zone and really causing adverse remodeling. So I think there's a number of different places that we can actually intervene, and I think this is going to be a very exciting period to continue this work and really, really kind of settle the questions on how hemorrhage actually drives real adverse outcomes in post-MI patients.
Excellent synopsis of clinical applications there, Rohan. Congratulations for all the work that you've done to expand this knowledge base and to educate us more about hemorrhagic myocardial infarction. Any closing remarks for the episode and for the podcast? And where do you see cardiac MR evolve and develop in clinical applications?
Thank you. I think cardiac MR is a very exciting tool to characterize tissue and tissue damage and to serially assess the efficacy of therapies. I think that's really where cardiac MR is going to shine. It has already done that in the space of thalassemia and how we control iron in the heart so that patients don't get into chronic heart failure. So this would be another example. Of course, the number of patients that we can actually have an impact on and really, limit the time before they can even develop or hopefully even prevent the development of heart failure, I think is going to be driven largely by our ability to do these non-invasive imaging, use those methods like MRI. So I think imaging will play a big role, but I think there's a lot of activity that even in my group that are there that can actually do some things, perhaps not even without imaging, to be able to look at hemorrhagic infarction. And I think that's going to be another area that is going to be coming up as well. But last, I want to take the opportunity to really thank so many people that have contributed to the development of these ideas and concepts and constructs and things that have enabled us to really understand what hemorrhagic infarction is. Clearly, there's more to do, but I think, looking back 15, 20 years, I think we have come a long way in our understanding of hemorrhagic infarction. So for that, I'm really excited and really looking forward to the future research that we will be doing.
Well, excellent. Thanks again, Rohan, and I'll talk to you soon.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.